Chapter 5, Anticipatory Guidance for the Infant and Young Child. After the caries risk assessment and clinical examination is complete, it is time to speak to the parent, guardian, or primary caregiver about the findings. Advice needs to be given on maintaining or improving their child's oral health, as well as topics the parent needs to understand before the child's next visit to the dental home. This is called anticipatory guidance.
Anticipatory guidance is a notion that's been used in pediatric medicine for quite a while. Anticipatory guidance is the education that's given to a parent or a caregiver about their child's care and development that they'll need to know in the upcoming months or years. In dentistry, anticipatory guidance for a 1 or 2 year-old might include a discussion of fluoride or oral hygiene, diet, or the like.
Let's first take a look at fluoride. Exposure to fluoride in the proper amount is important for the child's oral health. Fluoride has been shown to provide several caries protective mechanisms, including enamel remineralization and altering bacterial metabolism. As part of anticipatory guidance, parents should be told that their child's teeth should be brushed or cleaned twice a day with a fluoridated toothpaste. A pea-sized amount of toothpaste should be used for children 2 to 5, and a smear of toothpaste for children younger than 2. And parents of young children should always supervise them as they brush to assure that all the biofilm is removed. Fluoride supplementation can be prescribed to ensure the child has the proper fluoride exposure, using the schedule approved by the American Dental Association, the American Academy of Pediatrics, and the American Academy of Pediatric Dentistry. It is important to determine a child's dietary sources of fluoride before prescribing supplements. If the child receives too much fluoride, they may develop fluorosis, which has been associated with excessive fluoride intake during enamel development. Sources of dietary fluoride may include drinking water, beverages, infant formula, and toothpaste. We now turn our attention to oral hygiene. The anticipatory guidance for oral hygiene begins by explaining to the parent that an infant's teeth should be cleaned with either a washcloth or soft toothbrush as soon as they erupt. Doing so will help reduce cariogenic bacterial colonization. Proper positioning during tooth cleaning can make the process much easier, so the knee-to-knee process with 2 persons is recommended for very young children. If only one person is available, sitting on a couch with the child's head in the person's lap is also an effective method. Using dental floss when adjacent teeth are touching is also important in reducing interproximal caries. Instruction on diet is also a critical part of anticipatory guidance. After the eruption of the first primary teeth, preventing early childhood caries is possible by restricting bottle or breastfeeding to normal meal times and not allowing the infant to feed anytime they would like or while sleeping. Early childhood caries is associated with frequent bottle feeding at night, breastfeeding on demand, and the extended and repetitive use of a no-spill training cup. High-risk dietary practices appear to be established early, most likely by 12 months of age, and are then maintained throughout early childhood. For this reason, parents should be educated about sugars and carbohydrates and their contribution to the process of demineralization and remineralization, as well as how acids in carbonated beverages can have a damaging effect on enamel. Excess consumption of carbohydrates, fats, and sodium can also contribute to poor overall health. Dietary analysis and the role of dietary choices on oral health, malnutrition, and obesity can be addressed with the aid of the U.S. Department of Agriculture's Food Pyramid and the Center for Disease Control and Prevention's Health Statistics Growth Charts. These provide guidance for parents and help promote a better understanding of the relationship between a healthy diet and proper development. We now move on to injury counseling. Facial trauma can result in fractured, displaced, or lost teeth and can significantly affect the child in many ways. During anticipatory guidance, practitioners should provide age-appropriate injury prevention counseling for orofacial trauma. These discussions should include a review of items that may be hazardous to a child, such as pacifiers, electrical cords, and play objects, as well as items that can be beneficial, such as car seats. The greatest incidence of trauma to the primary dentition occurs between ages 2 and 3, which is a time of increased mobility and motor coordination development. As this occurs, parents should be counseled on additional safety and preventive measures. As part of the anticipatory guidance process, the parent should be given information on what to do in the event of a dental injury. If a parent is aware of first aid measures and the need to seek immediate treatment if an injury occurs, outcomes would significantly improve. Let's shift our attention to the final aspect of anticipatory guidance: non-nutritive oral habits. Non-nutritive oral habits, including pacifier and finger habits, may apply force to teeth and dentoalveolar structures. Although early digit sucking and use of pacifiers is considered normal, habits of sufficient frequency, intensity, and duration can contribute to harmful changes in occlusion and facial development. As part of anticipatory guidance for the infant and young child, it is important to discuss the need for early sucking, as well as the need to wean the child from the habits before malocclusion or skeletal problems occur. Early dental visits provide an opportunity to encourage parents to help their children stop sucking habits by age 3 or younger. After anticipatory guidance is completed, the child's visit is concluded and a recall appointment is made. The caries risk assessment and clinical judgment will guide the practitioner's decision on when the child should be seen for recall. Some children will need to be seen in 6 months, and some sooner than that. Children who have a low caries risk may not need to be seen for a year.